Finally, Leopard syndrome, a rare genetic condition that affects multiple body systems and leaves its mark on the ECG. What does Leopard stand for, and how is this fascinating multi-system condition identified?
Leopard is a wonderfully descriptive acronym standing for lentigines, small dark spots on skin, ECG abnormalities, ocular hypertelorism, widely spaced eyes, pulmonary stenosis, narrowed heart valve, abnormal genitalia, retardation of growth, and deafness. It was first interpreted clinically in 1936, but given its distinctive acronym and further characterized in 1969 by Robert J. Gorlin and colleagues. It's also known by other names, like Noonan syndrome with multiple lentigines highlighting genetic overlaps.
What's the genetic root of this broad condition? Is it something inherited?
Yes, it is. The genetic root is typically a missense mutation in the PTPN1 gene on chromosome 12. This mutation reduces the activity of protein tyrosine phosphatase, an enzyme crucial for cell growth and development. It can be inherited in an autosomal dominant fashion, only one mutated gene needed, or occur sporadically. It has high penetrance, meaning most with the mutation show signs, but varied presentations. Not everyone has all features or the same severity.
So the ECG abnormalities are just one piece of a much larger puzzle. What other features define Leopard syndrome beyond the heart? Give us a sense of the full systemic impact.
You're absolutely right. It's a complex, multi-system puzzle. The lentigines are key. Distinctive brown-black macules like non-sun-induced freckles on the chest, back, face, arms, but not mucous membranes. They often appear with or after hypertrophic cardiomyopathy. Other common features include ocular hypertelorism, pulmonary stenosis symptoms, abnormal genitalia, cryptospermism, hypospadias, delayed puberty, stunted growth, and sensorineural deafness. Skeletal features like pectus excavatum, sunken chest are common. While mitral valve prolapse and septal defects can occur, hypertrophic cardiomyopathy is one of the most serious and common comorbidities, often dictating prognosis.
What are the specific ECG abnormalities seen in Leopard syndrome, and how do doctors confirm a diagnosis given its wide range of symptoms?
On the ECG, you can typically observe signs of left or biventricular hypertrophy, thickened heart muscle. There can also be repolarization abnormalities, prolonged QT interval, and various AV blocks. To confirm diagnosis, a multi-system evaluation is needed. Echocardiography assesses valvulopathies and hypertrophy. Holter monitoring and stress testing detect arrhythmias. Genetic analysis is definitive for the PTPN1 mutation, and family screening is recommended. Prenatally, if a fetus shows hypertrophic cardiomyopathy, Leopard can be suspected and confirmed with genetic testing of amniotic fluid or chorionic villi.
What is the definitive way to diagnose Leopard syndrome, particularly with all those different presentations?
The diagnosis is confirmed by specific clinical and genetic criteria. The definitive way is the presence of multiple lentigines, plus at least 3 of the other main features from the Leopard acronym: structural cardiac defects, ECG abnormalities, genitourinary abnormalities, neurological abnormalities, craniofacial deformities, growth disorders, and skeletal malformations. If lentigines are absent, diagnosis can still be made by finding at least 3 of those other characteristics in the patient or close family, indicating the broader syndrome.
What's the overall outlook for individuals with Leopard syndrome?
The prognosis varies significantly depending on cardiac involvement. Patients with no or mild cardiac abnormalities generally have a good prognosis but require annual monitoring. However, those with severe valvulopathies or hypertrophic cardiomyopathy face a high risk of arrhythmias and sudden cardiac death. Valvulopathies may require surgery. Hypertrophic cardiomyopathy can be managed pharmacologically or with procedures like myectomy, or pacemaker implantation, depending on severity and complications. It requires lifelong vigilance. Quiet for 2 seconds. Conclusion.
Wow. What an absolutely incredible journey through the heart's hidden electrical signals and structural surprises. It's truly amazing how much vital information a seemingly simple ECG can hold.
Indeed. The ECG remains a remarkably useful, widely available, and non-invasive tool. Its sensitivity, combined with modern tech like Holter monitors and field ECGs, makes it indispensable. With cardiovascular disease still a leading cause of death globally, it's absolutely vital for healthcare professionals across all specialties to be adept at interpreting not just common findings, but these rarer, more complex ones too.
So what does this all mean for us, the learners, in the bigger picture? What's the ultimate takeaway from this deep dive?
Well, the knowledge and understanding of these syndromes are truly critical for early detection, appropriate treatment, and ultimately preventing fatal arrhythmias and sudden cardiac death. The potential for misdiagnosis and dangerous treatment delays is very real when these conditions aren't recognized. Each pattern tells a critical story that healthcare professionals must be prepared to read, potentially transforming dire situations and quite literally saving lives.
If you could distill our deep dive into a few top essential takeaways, what would they be?
Okay, first, the ECG is not always straightforward. Crucial diagnostic clues, like in Welland syndrome, can appear when symptoms are absent. That counterintuitive presentation is vital. Second, the heart can react physically to intense emotional or allergic stressors, as we saw in Takotsubo and Kuhn syndromes, showing a profound mind-body or immune cardiac connection.
Right.
Third, not all serious heart conditions are caused by blocked arteries. Some are purely electrical or genetic, like Brugada or Leopard, shifting focus from plumbing to wiring. And finally, some athletes face unique cardiac risks, like pathophysiology syndrome, due to strenuous training, emphasizing that fit doesn't always mean no heart risk. It highlights the importance of personalized approaches.
To leave you with something to ponder, considering the intricate and often subtle signs of these syndromes, what other seemingly normal physiological responses might be masking critical underlying health issues that we are yet to fully understand? Makes you wonder how many more hidden messages our bodies are trying to send us. Quiet for 2 seconds. Multiple choice questions. MCQs. All right, it's time to test your newfound knowledge with some quick questions based on our deep dive. Don't worry, we'll give you the answers and a quick explanation. Ready? Number 1. Which ECG syndrome is characterized by T-wave changes in V2, V3 when the patient is pain-free, indicating a critical LAD artery stenosis? A. De Winter syndrome, B. Takotsubo syndrome, C. Welland syndrome, or D. Brugada syndrome?
The answer is C, Welland syndrome. This one's unique because its classic T-wave changes in V2, V3 appear when the patient feels fine, signaling that intending LAD blockage.
Okay, number 2. In De Winter syndrome, what is a key ECG finding in precordial leads that differentiates it from a typical STEMI? ST segment elevation greater than 2 millimeters, B. Deep Q waves, C. Absence of ST segment elevation with upsloping ST segment depression at J point and peak T waves, or D. Prolonged PR interval.
That would be C. Absence of ST segment elevation with upsloping ST segment depression at J point and peaked T waves. Even though it's a STEMI equivalent, De Winter typically lacks that ST elevation, showing specific depression and peaked T waves instead.
Number 3. Kuhn syndrome is defined by the simultaneous occurrence of acute coronary syndrome, ACS, and what type of reaction? A. A viral infection, B. A systemic allergic reaction, C. A cerebrovascular accident, or D. Renal failure?
The answer is B, a systemic allergic reaction. Kuhn syndrome is that combination of ACS with an allergic or hypersensitivity reaction involving mast cell activation.
Question 4. What emotional or physical trigger is commonly associated with Takotsubo broken heart syndrome? A. Extreme physical exertion only. B. Chronic inflammation. C. Heartbreaking events or intense stress, emotional or physical. Or D. High cholesterol diet.
It's C, heartbreaking events or intense stress, emotional or physical. Takotsubo is strongly linked to sudden, severe emotional or physical stressors causing that catecholamine surge.
Number 5. Yamaguchi syndrome is a specific type of hypertrophic cardiomyopathy, primarily affecting which part of the heart, often resulting in a distinctive ace of spades appearance on imaging? A. The right ventricle. B. The left ventricular apex. C. The left atrium. Or D. The interventricular septum.
The distinctive shape points to B, the left ventricular apex. Yamaguchi syndrome specifically involves hypertrophy of the LV apex.
Okay, number 6. Which of the following is a classic ECG triad for Wolff-Parkinson-White WPW syndrome? Short PR interval, normal QRS, absent delta wave. B. Long PR interval, wide QRS, inverted T wave. C. Short PR interval, wide QRS, presence of a delta wave. Or D. Normal PR interval, wide QRS, ST segment elevation.
The classic triad is C. Short PR interval, wide QRS, presence of a delta wave. This shows the accessory pathway bypassing the AV node.
Number 7. Lone-Gannon-Levine LGL syndrome is distinguished from WPW syndrome by the absence of what ECG feature, despite having a short PR interval, A. Q waves, B. T wave inversions, C. Delta wave, or D. ST segment depression.
The key differentiator is C, delta wave. LGL has a short PR but a normal QRS, and crucially, no delta wave.
Question 8. The diagnostic type 1 ECG pattern for Brugada syndrome involves what specific finding in the right precordial leads, V1, V3? A. ST segment depression greater than 1 millimeter. B. Coved ST segment elevations greater than 2 millimeter, followed by an inverted T wave. C. Prolonged QT interval. Or D. Flat T waves.
The diagnostic pattern is B, coved ST segment elevations greater than 2 millimeters, followed by an inverted T wave. That specific cove-type elevation is the hallmark for type 1 Brugada.
Number 9. Frederick syndrome is the simultaneous occurrence of atrial fibrillation or atrial flutter and what other major cardiac event? A. Myocardial infarction. B. Complete heart block. C. Ventricular tachycardia. Or D. Supraventricular tachycardia.
Frederick's is the combination of AFib or flutter with B, complete heart block. third-degree AV block.
And finally, number 10. Pathophysiology syndrome, affecting young and middle-aged athletes, is characterized by recurrent episodes of what arrhythmia, often linked to strenuous long-term training. A. Ventricular fibrillation, B. Atrial flutter, C. Paroxysmal atrial fibrillation, or D. Sinus tachycardia.
That athlete-specific syndrome is characterized by C. Paroxysmal atrial fibrillation, linked to that long-term training and cardiac remodeling. Outro.
And that wraps up another truly illuminating deep dive. We hope you've gained a clearer understanding of these fascinating and sometimes hidden heart conditions that remind us how incredibly complex and resilient the human body truly is.
Understanding this broad spectrum of ECG syndromes is really a testament to the power of medical observation and the ongoing quest for precise diagnosis. Each unique pattern tells a critical story that healthcare professionals must be prepared to read to help ensure the best possible patient outcomes.
We're always learning, and we love sharing that journey with you. Until our next deep dive, stay curious, stay informed, and keep exploring.